Hi, this is Kyle Harrison doing our final module on post-resuscitation management as part of our ACLS and CRM review for the iPad. So after you successfully resuscitated a patient, there's some important things you need to note about the post-resuscitative period, which can improve the long-term viability of the brain and the heart, and improve the improve your chances of a successful outcome from your resuscitation. Just because you've gotten them back doesn't mean that there's not other things that need to be done in order to provide the best outcome for your patient. So let's get started. So one thing that's important to note is that there is a post-resuscitation syndrome, and this is a syndrome that's created by ischemia, reperfusion, and then multi-system organ dysfunction. And you can imagine, if any organ is ischemic as it's reperfused, there's lactate and toxic metabolites as well as free radicals. There's often organ dysfunction that results in the organ not performing as well as it should as it recovers. And then eventually it gets back to functioning as good as it's going to get, maybe performing less well than before the insult. Well, imagine your whole body is down, and that's what happens with cardiac arrest. So you have brain and heart and lungs, renal, etc. All these organs have taken a hit during their resuscitation period. So they're all going to have reperfusion, they're all going to have reperfusion sequelae, and they're all going to have hypofunction and dysfunction post-resuscitation that you have to manage. It's almost like a Sears-like pathophysiology. So a systemic inflammatory response syndrome results from the reperfusion. It causes a vasodilatory, almost like a vasodilatory shock state. This in conjunction with cardiogenic shock, often from the cardiac dysfunction following an arrest. The patient often has ongoing cardiac instability with arrhythmias or poor contractile function, either from the primary event, from the prolonged ischemia, as well as epinephrine, which is needed for the resuscitative period, but it can also cause some ongoing instability as well as dysfunction. Have to remember that the patient coded for a reason, so you also are dealing with the underlying pathophysiology in the post-resuscitative period. So unless it was a primary healthy person with an arrhythmogenic arrest, you still have to deal with whatever the primary cause of the arrest was, which also makes the management difficult post-resuscitation. And you need to understand that this post-resuscitative phase is an extremely high-risk period for the patient. These patients are extremely critically ill. Often patients arrest more than once, maybe multiple times. So you need to understand that there's a period of decompensation that will occur potentially in these patients, and be prepared for that. So obviously all the patients that have suffered a cardiac arrest are going to go to the ICU for post-resuscitation management. Even a extremely brief VT or VFib arrest should probably go because they've obviously had an arrhythmogenic arrest. But it's really a no-brainer. These patients are critically ill. Most of them are going to have the need for ongoing cardiopulmonary monitoring as well as possible cooling, and a lot of them will be intubated, so they're all going to go to the ICU. It is important when you transport these patients, if they're not in the ICU and you transport them to the ICU, that you have full resuscitative capabilities with you. So this includes a defibrillator. Since these patients can decompensate very rapidly, it's important that you have the ability to basically run a code wherever you are. If the patient codes again in the elevator, you need to be able to code them. If they go into ventricular fibrillation in the hallway, you need to be able to shock them out of it. So have a defibrillator, have a monitor. Consider even invasive monitoring at the bedside. If you have the resources, you may be able to place it an arterial line. If you didn't place it for the resuscitation, consider placing it before transporting, so you can do beat-to-beat assessment of the blood pressure. So you can see when they start becoming hypotensive, you can intervene maybe intervene with a smaller dose of drug than waiting for the patient to become pulseless and then starting the arrest again. So once again, consider early arterial access for monitoring. Once again, transport with full cardiopulmonary monitoring, including defibrillator. So let's go over each component. So respiratory, the post-resuscitative period. If the patient had a laryngeal mask airway placed, which is encouraged if you're not a regular intubator, as we talked about in the other modules, this is going to have to be changed out to an endotracheal tube, but that should be done by an experienced provider. So call your anesthesiology colleagues or your intensivist who are skilled with intubation, and they can change that over. Once they're intubated, or if they were intubated during the rest, it's important to avoid overventilation. So your goals should be an end-tidal CO2 of 35 to 40, which will approximately be around 40 to 45 on an arterial blood gas. It's important because you don't want to overventilate, which would cause cerebral vasoconstriction, and you don't want to underventilate, which would cause vasodilation, thereby possibly increasing the ICP. So just right, keep the PCO2 right at 40 to 45 on arterial blood gas. You want to avoid excessive intrathoracic pressures. That's going to potentially make the cardiovascular stability a little more challenging if you have a intrathoracic pressure, so you want to watch for that. Monitoring, obviously, for any signs of pneumothorax. Chest compressions can cause a pneumo, and then under positive pressure that may actually develop to tension pneumo, so monitoring for bilateral breath sounds, maintaining, you want to get a chest x-ray post-resuscitation, check placement of your endotracheal tube, that it's not in a main stem. Sometimes the assessment can be challenging during the actual code, so once the patient's back, you can take time to actually assess these more fully. And you want to wean your FiO2 to keep your sats, you're okay with the sat of 94, and you don't have to have 100%. So you're better off taking your FiO2 the lowest possible. Avoid 100% if possible. That may be generating free radicals and causing oxygen toxicity. Oxygen delivery, as long as the saturation is greater than 94, is going to be adequate in this post-resuscitative phase. Don't stay on high FiO2. Wean as much as possible. Cardiac, obviously, this is a big deal because the cardiac arrest is always going to involve some degree of cardiac dysfunction. So you want to support the cardiac output and blood pressure as needed with vasopressors. So, as we talked about before, the patient may have a vasodilatory kind of systemic inflammatory response picture, as well as cardiogenic shock picture. So depending, you're going to have to make an assessment of why you think the blood pressure is sagging post-resuscitation. Is it a pump function? Is it a vasodilation? And treat accordingly. So the common vasopressors, obviously dopamine, and doses from 2 to 20 mics per kilo per minute. Epinephrine from 20 to 200 nanos per kilo per minute, or 2 to 20 mics per minute. Phenylephrine, which is predominantly for vasodilatation. Dopamine and epinephrine are both going to be contractility agents. Phenylephrine is for low afterload and a systemic inflammatory response type picture. May be difficult to make this assessment without additional monitoring, so consider a pulmonary artery catheter, PA cath, may help you decide the cause for the cardiac hypotension, and consider an echo. You'll determine how the heart's functioning. Are there regional wall motion abnormalities, underdiagnosed valvular disease, and to see is it low cardiac output or low SVR that's causing the hypotension, so you can make a better assessment on why the patient's hypotensive. You're going to consider emergent coronary revascularization with percutaneous interventions in the cath lab for any VFib arrest, especially any out-of-hospital VFib arrest, but consider for anyone who has a EKG findings or a strong clinical history of myocardial infarction. You can consider an aortic balloon pump for a failing heart. So if the contractility is still poor, the patient's hypotensive, consider placing an intra-aortic balloon pump. Once again, either your cardiac surgeons or your cardiology colleagues will kind of assist you in placement of this and the balloon pump. So neurologically and acid-base. So for acid-base, it's important to monitor your glucose and treat any hyperglycemia, but it's very important to avoid hypoglycemia. You need to keep them in this 140 to 180 range. You don't want to either end is bad. Either hypoglycemia is damaging, hyperglycemia is damaging. You want to keep them with a goal of 144 to 180. You got to monitor your acid-base status and electrolytes, treating those accordingly. Often they can be deranged depending on the resuscitation, prolongation, how long it took to resuscitate the patient, or any underlying electrolyte abnormalities. You're going to need to replace these post-resuscitation. Neurological, so very important, because once you get them back, you're basically trying to save the brain, because if you're going to have any long-term viability of the patient, it's going to have neurological recovery is a pressing matter. So primary determination of long-term morbidity and mortality is neurological recovery. So things to do to help protect the brain. So avoid hypotension. You need to perfuse the brain. So don't allow periods of hypotension, even though you know they may be coming. You need to be aggressive and treat them. Avoid hyper or hypocapnia, as we talked about, carbia. So you want to keep the PaSO2, as we talked about, 40 to 45. Avoid hyper or hypoglycemia, as we talked about. And this is the big one. You're going to avoid hyperthermia at all costs. So if the patient becomes febrile or starts generating, it starts becoming warm, you want to prevent hyperthermia at all costs, and you want to consider hypothermia. And we're going to talk about hypothermia in a moment, but absolutely don't let them get hot. And then a subset of patients, you're going to actually cool post-resuscitation. And then you want to avoid increases in intracranial pressure of the brain. As any other organ is going to, as a reperfusion occurs, there's going to be swelling, and you want to keep the ICP down. So keep the head of the bed elevated 30 degrees, and it will help promote venous drainage, which may help decrease your ICP. You want to avoid sedation immediately post-arrest until you're able to assess the neurological status. And the Glasgow Coma Scale is still probably the best indication of a gross assessment of neurological status. A low Glasgow Coma Scale has a poor prognostic prognosis, but in the early stages, you can't make that assessment. So you likely will need to obtain neurological consultation to help determine the prognosis, and you're supposed to wait at least 72 hours to really determine what neurological injury has occurred before making those determinations about withdrawal of support, etc. So hypothermia. So this is emerging and ongoing research shows that active cooling post-arrest has improved the neurological recovery in selected patients. So in some patients, this is a wonderful thing. It absolutely improves their brain. Others, it may not. So there are some strong indications, some questionable, but a lot of people are saying it's worth it for an attempt, at least on a potentially salvageable patient, to cool them. So cool all comatose patients that have suffered an out-of-hospital VT or VFib arrest. These are strongest recommendations. So otherwise healthy or otherwise patient on the outside has a VFib, VT arrest, the best chance at neurological recovery is going to be cooling. You can consider cooling in all other comatose patients. So VFib in-house arrest, PEA, asystole, both in and out of hospital arrest. You can consider cooling in these patients. Once again, always in out of hospital VFib, VT, considering all the others. And this is something that you likely are going to need to get consultation with your neurologist or neurocritical care, ideally, to help make this determination about cooling. But you need to make that decision pretty quickly, because you want to cool them as rapidly as possible once the decision is made to cool the patient to help protect the brain. So protocols have been established in a lot of intensive care units to help with the cooling, but generally you want to start as soon as possible, and you want to cool them as quickly as possible. So ice packs on the patient and the axilla and the groins, the areas where you have vascular supply close to the skin to try and really cool the patient. You can use active cooling devices. These are encouraged. They're Arctic Sun, Intercool, invasive monitoring. The different ways you can cool patients. It's above the scope of this lecture, but know that there are active cooling mechanisms that you can employ, and likely should employ some degree of active cooling to get the patients cool quickly. You're going to sedate them as indicated, because you will need to paralyze these patients to prevent shivering. Shivering is going to increase the myocardial oxygen demand. It's going to potentially increase ACP, so you need to prevent shivering. So as you cool the patient, you're going to have to paralyze them with a neuromuscular blocking agent. Therefore, you should provide some degree of sedation, even if they're comatose in the initial period. You may need to sedate them if you're going to paralyze them. Your goal is to cool to 32 to 34 degrees, and you're going to cool them for 24 hours. And then you're going to let them passively rewarm. So it's important that you don't necessarily actively rewarm them per se, because you may overshoot and make them hyperthermic. So passive rewarming, most people are encouraging that to kind of gently rewarm them over the next day or so afterwards. Obviously, you would have to have the patient fully warm before you decide to attempt to extubate the patient from the ventilatory support. But in general, you're going to cool them for 24 hours, let them rewarm passively, and then you're going to make an assessment of their neurological status after that point. So that's the basic overview on post-resuscitation management. Once again, it's a very critically ill period for the patient. Expect lots of instability, prepare for that. Active, aggressive cooling if indicated. Consult consultants, cardiologist, and neurologist as needed to help support the patients in the post-resuscitative period. And you will hopefully give your patient the best chance at meaningful neurological recovery post-resuscitation if you employ these techniques. Thank you very much. I've enjoyed working with you on this project.